Hello, everyone. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education. Thank you for listening to the recording, Germ Cell Ovarian Cancer 101. Before we begin, I'd like to tell you a little bit about Share Cancer Support. We're a national nonprofit dedicated to providing support and education to anyone affected by breast or gynecologic cancer, as well as community outreach. We recognize that cancer affects every community, so our programs are inclusive and welcoming to individuals of all races, ethnicities, ages, gender identities, sexual orientations, and backgrounds. In addition to webinars like this, we offer support groups, support lines, outreach, navigation, and other free programs. You can learn more by visiting our website at sharecancersupport.org. Now I'm excited to welcome our speaker, Dr. Robert Neff. The screen is yours.
Thanks, Maggie. As you mentioned, I'm Dr. Robert Neff. I'm a GYN oncologist, an associate professor at Ohio State University, at James Cancer Center in Columbus, Ohio. And I'm excited to talk with you all today about ovarian germ cell tumors. So as Maggie alluded to, we're going to do a ovarian germ cell tumor 101. So this is our agenda today. We're going to start off just by talking about what are germ cell tumors, going through a few benign and malignant types. We'll go through a little bit of the workup and diagnosis of these tumors, followed by the treatment. So talking about surgical management as well as going into chemotherapy management just a little bit. We'll touch on follow-up and discussion of what happens in recurrences of these types of cancers. And then finally, we'll talk a little bit about some of the future treatment directions that are exciting in the field coming forward. So what are germ cell tumors and how do we diagnose them? So ovary germ cell tumors are basically abnormal development of early germinal cells. So thinking of the eggs within the ovary, the cells that ultimately are used in procreation. One of the most common benign tumors encountered on ovaries are mature teratomas. And these are benign ovarian germ cells. The malignant types, the cancerous types, are rare. They make up only about 2 to 3% of all ovary cancers. And they're commonly found in children, adolescents, up through early adulthood, with a peak age of incidence around the early 20s. And they are more frequent in women of Asian or African descent. And so this little description here over on the left side of the screen kind of shows some of the different types of ovary cancers, and the box goes around the specific germ cell tumors that we're going to discuss. So how do women present with germ cell tumors? A common phrase you could hear is a pelvic mass found in a young female patient. And like other ovary cancers, the symptoms are vague. So patients will often describe pressure, pelvic pain that's not going away, that sticks around for a while. They may note that they have trouble with urinating or bowel dysfunction, constipation. So very vague symptoms, which are similar across really all types of ovary cancers. And due to the age of diagnosis, sometimes we actually see abnormalities with menstrual cycles as a symptom of these types of tumors, which somewhat relates to hormone production sometimes from the tumor. These masses can grow rapidly. And there are some other types of ovary cancers where the growth is not as rapid. So a change to a female patient's abdomen may be noted as well. So the workup and diagnosis, really symptoms or exam findings should lead to imaging. And I think this is an important moment, really, as a physician who takes care of patients with ovary cancer to kind of discuss patients being an advocate for themselves. As I mentioned before, these symptoms are vague, and many times it can take 1, 2, or 3 visits for patients to get an adequate workup. And so I think being vigilant as a patient and being an advocate for yourself is very important through any of these diagnoses, and especially in this case of a germ cell tumor, because so often they are found in younger patients, and an ovary cancer may not be at the top of any physician's list of things that could be going on. So I just wanted to take that moment now for your patient audience to discuss that. In terms of imaging, pelvic ultrasound is usually the first step. And this is a example on the right side here of what a pelvic ultrasound might look like for a germ cell tumor. But a CAT scan is also acceptable, and those are called CT scans. There's really no defining ultrasound characteristics for malignant germ cell tumors, meaning we can't make a diagnosis just on imaging alone. These tumors are more commonly unilateral, meaning that only one ovary is affected. There are a couple exceptions to that. So as I mentioned before, teratomas, benign mature teratomas are some of the more common benign masses that we see on the ovary. And about 10 to 15% of those can be bilateral, meaning on both sides. And that's also the same for something called a dysgerminoma, which we'll talk about in a minute. And about 10 to 12% of those can be bilateral. Surgical resection is usually required for diagnosis. So I think another question that I often get as a physician is, why can't we just biopsy the mass? And I think that goes to the fact that many cancers are often diagnosed through a biopsy as opposed to a surgical resection. The ovary is unique in some ways in that it resides in the pelvic cavity without really a covering over it. And the tumors that grow often are growing from the surface or growing out to the surface of the ovary. And ovary cancers, not just germ cell tumors, spread like dandelions. So the cells are released from the surface and they can attach elsewhere within the body. So puncturing the mass, which would be required through a biopsy, increases the risk of spread and increases the stage. And so that's why we do not biopsy ovary masses. Another part of the workup and diagnosis for these types of tumors are drawing what are called tumor markers. And those are blood tests that look for proteins in the body, which may be released by malignant tumors. And they're actually very useful in germ cell tumors, both for diagnosis and also monitoring treatment. And I've just listed 3 of the more common ones that we will typically get when we're concerned about a germ cell tumor. And those are alpha fetoprotein, or AFP, HCG, which is the pregnancy hormone, and then lactic dehydrogenase, or LDH, are kind of the 3 more common ones that we will get for germ cell tumors. So this is not an exhaustive list, but this is kind of a 2-column list on the types of ovary germ cell tumors. As I mentioned, mature cystic or solid teratomas are the most common benign germ cell tumors and most common germ cell tumors that we see. And then on the right side here are the malignant types: the dysgerminoma, yolk sac tumor, immature teratoma, and then rarer types like non-gestational choriocarcinoma and mixed germ cell tumors. And what I wanted to do next was just kind of go through a few of the more common of the malignant germ cell tumors. So starting with dysgerminoma as being the most common of all malignant germ cell tumors. And as I mentioned earlier on, these can be bilateral. However, usually at the time of surgery, there is a visible abnormality on the ovary and not microscopic. And that's important because many times physicians may see the other ovary and be worried, oh, is there something there? But if the ovary appears normal, it most likely is. And that's important because early stage dysgerminomas can oftentimes be observed as opposed to needing patients to get chemotherapy for treatment. LDH is the most common tumor marker for dysgerminomas. Now, it is not specific. unfortunately, because LDH can be elevated for other causes in the body, but it is something that is more commonly elevated in this tumor type. So immature teratoma being the next one I wanted to discuss. Again, as I mentioned before, the difference is benign teratoma, or is called a mature teratoma, versus an immature teratoma, which is technically a cancerous lesion. Um, mature tumors or mature teratomas are typically the types of masses that sometimes we can see hair or teeth inside. And that goes back to the development of these types of tumors and what types of cells often make up those tumors. For immature teratomas, meaning the cancerous type, the grade of the tumor can impact treatment. And that's something that we find on a pathology report after surgery. It relies on an assessment of something called immature neural tissue, which really is just a complicated term that pathologists use to look under the microscope and tell us what the grade of a cancerous tumor is in this type. And when treated with chemotherapy, immature teratomas can actually reemerge as benign mature teratomas. And that is something that is important for us who treat these types of tumors to watch out for in surveillance with CAT scans, because that can be difficult to treat if too much of that tumor grows. And lastly are yolk sac tumors, and these count for about 10 to 20% of malignant germ cell tumors. The AFP is the tumor marker of choice really for these types of tumors. And these can oftentimes have rapid progression. They're still commonly diagnosed at stage 1, but because of the poorer prognosis, even stage 1 tumors are all offered chemotherapy. So now I want to switch gears and do a little discussion on the surgical management and chemotherapy management of germ cell tumors. So surgical management of ovarian germ cell tumors is really determined based on findings and the patient's desire for fertility, which we'll talk a little bit about on the next slide. And really, we're more concerned about fertility preservation due to the age of the typical patient population for germ cell tumors. And it is very reasonable to leave non-affected ovaries, which is different than some other types of ovary cancers that we treat. So surgery primarily, if the primary tumor, meaning the main mass, is larger, typically an open incision, meaning an incision up and down on the abdominal wall, is required. If the ovary mass is smaller, then it's reasonable to try what's called a minimally invasive surgery. So sometimes that may be laparoscopic, or sometimes that can be robotic. And the main goal, again, is to remove the affected ovary and tumor. Now, if we get an answer during the operation that the mass looks like a cancer, then typically we will also do a staging procedure. And that can include removing the omentum, which is really just a fat storage tissue that sits over top of the bowel. And it's an area where sometimes cancer cells find their way onto. We take some biopsies from around the peritoneum. And you can think of the peritoneum as kind of like the wallpaper on the inside of the abdomen. Again, we assess the remaining ovary, and occasionally we will do lymph node biopsies to make sure that no cancer cells have found their way into the lymph nodes. So as I mentioned before, because of the age of finding these types of tumors, fertility preservation is probably a very key part of treatment of these types of tumors. And as any physician who treats these tumors, we really have to be aware of all the options for fertility preservation. As I mentioned, these tumors are most commonly stage 1, meaning that we typically don't see both ovary involvement. And attempting to preserve the uterus and one ovary is really ideal. I think in rare cases where you have significant concern for disease on the other ovary, it's reasonable to consider preservation of the uterus only for in vitro surrogate embryo transfer. As I mentioned before, a biopsy of the normal ovary, if it looks normal, is not needed during surgery because that can sometimes increase the risk of ovary dysfunction. Staging is still recommended, even when we do fertility preservation, because that helps with the chemotherapy decision. And we know that even in the best case scenarios, when we are trying to preserve fertility, chemotherapy can have an effect on fertility. So we really want to make sure we get all of the tissue answers that we need in order to make the decision as to whether or not additional treatment is needed. And I think it's important also to note for your patient population or the people who may be watching this that this type of tumor is one that we should be working in conjunction with a reproductive endocrinology specialist or an infertility doctor, because they can oftentimes discuss some of the options available for fertility preservation, whether that's egg retrieval of the non-affected ovary, or embryo creation and storage. These are important things to note, I think, for a patient population that is younger. So what happens if we find metastatic disease at the time of surgery? Really, for all ovary cancers, there should be a consideration for tumor debulking, or what that means is basically trying to remove all visible tumor during the surgery. So anything that we see on any surface, we're trying to remove, as that we think is the best option for anyone with an ovary cancer. And I think it's important to note, especially as a GYN oncologist, that surgical input from someone with GYN oncology training really should be taken into account here. Data is limited because of the rarity of these types of tumors as to whether or not doing primary surgery for metastatic disease is the best option. But the data that we have seems to favor doing a debulking. The one thing I will say is that germ cell tumors tend to be very chemosensitive, meaning treatment with chemotherapy is oftentimes going to work in shrinking or getting rid of these tumors. And so I think that sometimes can limit the need of aggressive surgery up front. And I think should be taken into account, especially for our younger patients who may be cured of these tumors. And we don't necessarily want to leave with long-term complications from surgery. So this is just a little diagram of kind of some basic staging for germ cell tumors. Stage 1 being limited to the ovaries, either one or both. Stage 2 is when an ovary is involved and there may be some involvement of some of the tissues around the ovary in the pelvis. Stage 3 is when there's involvement of the ovary as well as some surface outside of the pelvis or lymph nodes. So as I mentioned, the omentum being a large surface that sits outside of the pelvis. So that would, if it was positive, be a stage 3. And then stage 4 is just distant metastatic disease. So whether outside of the abdomen or within the liver, being our highest stage for these types of tumors. So who needs chemotherapy? Again, there is some nuance to this discussion, but I kind of put together when it's not recommended and generally when it is recommended. So when it's not recommended are our very early stage 1A, grade 1, as I mentioned earlier before, the grade being important for an immature teratoma, and stage 1A, pure dysgerminoma. And what I mean by pure is, as I think from an earlier slide where we talked about mixed germ cell tumors, many germ cell tumors have a mixed component, meaning maybe a little bit of an immature teratoma mixed in with a dysgerminoma. And that can have an effect on whether or not we are offering chemotherapy. But when the tumor is a pure dysgerminoma, meaning no other combination, and it's our earliest stage, stage 1A, chemotherapy is generally not recommended. And so really that leaves all other stages of immature teratoma and dysgerminoma, as well as other germ cell tumors, all stages recommending chemotherapy. So what should we expect from chemotherapy? Really, there were multiple earlier clinical trials in our field that led to a pivotal trial in germ cell tumors. And that really set the standard of care for frontline chemotherapy being BEP, BEP. And that's bleomycin, etoposide, and cisplatin. And the P really stands for the trade name of cisplatin. And what we know is that from chemotherapy and surgery, we have a very high cure rate of these tumors, 90+%, which really is not the case in other types of ovary cancers. And that really even also includes advanced disease. So our stage 3s and 4s still have a very high cure rate with chemotherapy for these tumor types. Typically, patients would expect to get at least 3 cycles of all 3 of these medications, and sometimes additional cycles are given based on the stage and the response of the tumor to the chemotherapy. So what about side effects? Very important as a provider to make sure that patients are very comfortable and understanding of what they're getting into and what side effects they may experience. So I've kind of listed some immediate acute side effects that we see from these chemo drugs, which includes hair loss, um, GI complications like nausea and vomiting, diarrhea or constipation. Nephrotoxicity, meaning kidney dysfunction, we can see sometimes with these chemotherapy medications. I think an important one that we are very cautious with is something called pulmonary fibrosis, which is a complication where inflammation and scar tissue can build up within the lungs due to bleomycin, so the B component. And we are watching very closely the function of the lungs during and before the chemotherapy. Typically, if we do run into any issues where we're concerned about that, we will simply stop the bleomycin as part of the treatment. And then I think another important one to mention also is hearing dysfunction. So sometimes patients may experience tinnitus or ringing in the ears or some degree of hearing loss. I wanted to bring up some late side effects. As I mentioned before, chemotherapy can have an effect on fertility because it may cause menstrual dysfunction. In rare cases, it may cause ovarian suppression or ovarian loss, so early menopause, which again would cause primary infertility, meaning that the ovarian function is no longer there, and thus getting pregnant in kind of the normal way or the way that we would think about is not possible anymore. And then a secondary late side effect sometimes are rare leukemias or lymphomas, which we think is due to the etoposide component. And that's dose dependent. So oftentimes for primary treatment of these types of cancers, we're not reaching the dose that would be needed to see that kind of risk of leukemia following the chemotherapy. So now I just want to talk a little bit about disease surveillance and what happens if we see a recurrence of this type of cancer. So again, we either have finished surgery or surgery and chemotherapy. What happens next? What I tell patients is that for these types of tumors, the vast majority of them, if they are going to recur, happen within the first 2 years. Dysgerminomas in particular, however, can reoccur much later. And so it requires a much longer surveillance for patients, over 10 years sometimes. But generally, it's a combination of an in-person visit in the office where we're doing examinations, we're talking about symptoms, we're sometimes drawing blood for those tumor markers that we talked about, and we're also getting imaging, typically with a CAT scan. And so all of that surveillance will happen roughly every 3 months for the first 2 years, and then every 6 months for the next 3 years. And then once we hit that 5-year mark, typically it's just a yearly visit. And continuation of CAT scans, I think, can be debated after 5 years. And I think it's important to note that the CAT scans are recommended because germ cell tumors, even if they have abnormal tumor markers at the beginning, can sometimes come back with normal tumor markers. So while we're following along, even if the tumor marker is normal, CAT scans can sometimes pick up on things that we might not have otherwise seen. And as I mentioned before, dysgerminomas should really be followed for at least 10 years. So in the unfortunate event of a recurrence of these types of tumors, the prognosis overall generally depends on what the initial response to the cisplatin therapy was. So overall, if something reoccurs and the patient was just observed after surgery, the prognosis is excellent, meaning that we would expect the chemotherapy to still achieve a cure. And those early stage GIST germinomas, about 20% of them can reoccur. But because they respond so well to chemotherapy, we are still able to cure patients. For those patients who may have a larger recurrence or a recurrence after prior chemotherapy, this is typically when I would recommend seeking high volume tertiary care, meaning a place that treats a lot of germ cell tumors with the understanding that higher doses of chemotherapy are often given, which can have a really significant impact on the bone marrow. And that's what that stem cell rescue typically is when we're trying to basically allow the bone marrow to kind of reemerge after these high dose chemotherapies. And so that type of treatment is very specific. And I think is a good thing for your population to know that that is really when you should be seeking kind of outside expert care. And it's also a time when we would talk to patients about clinical trial participation. Really for all of us who treat ovary cancers and any type of GYN cancer, clinical trial participation is really always going to be something that we will be considering and recommending if it's available for patients, and especially in this case. And so I just wanted to end on talking about a couple clinical trials that are ongoing for germ cell tumors. The first one is looking at how are we dosing that an upfront chemotherapy, that BEP, for high risk and metastatic germ cell tumors. So looking at not only the standard dosing, which would be roughly every 21 days, but looking at an accelerated dosing pattern, so every 14 days instead for a cycle of chemotherapy. The next one is really kind of a de-escalation, which is kind of an interesting idea in a trial in that we're wondering, are there some of these early stage but high risk patients that we could actually observe as opposed to giving chemotherapy, meaning just doing surveillance and not giving chemotherapy? So there is a trial ongoing looking at that. And then lastly, really for patients with recurrences, there are additional phase one, so early stage trials looking at newer medications or drugs that may provide benefit even for patients with germ cell tumors. And so it's really important, I think, to be an advocate for yourself if you're facing a recurrence of these types of tumors and asking your provider what clinical trials might be available. And if you don't have any, can you recommend any places that might? And so um, I just wanted to say thank you for having the opportunity to chat with you all today about this kind of rare but important type of ovary cancer, and wish you all the best.
Thank you so much, Dr. Neff, for sharing your time and expertise with us today. We really appreciate it.
Oh, you're welcome.